that.
All right, okay, great. Okay, so any other questions before we move on to KEP 65? All right, good. So basically, when you have a patient with pneumonia, you'd have to make a decision. Am I managing this patient on an outpatient basis? Or I want to admit this patient to a usual ward, or should I give this patient a special ward, a special care? And my point is, you don't admit every patient with pneumonia because there are varying degrees of pneumonia, and admission is based on the certain clinical features we look out for. Okay, so to help us make this decision, there's a criteria we call KEP 65, and this criteria enables us to make a decision on patients with pneumonia. What we want to do is we want to assess the patient and see if we can decide to manage this patient on outpatient basis, or we definitely have to admit this patient. Okay, so with a KEP 65, as the name suggests, it's just an abbreviation. So CURB and 65. The C there stands for confusion, and U stands for urea, R stands for respiratory rate, B stands for BP, and 65 is the age 65 of a patient. What is happening here is you're taking your patient and you're assessing the patient. So if you realize your patient is confused during assessment, that is one, a value of 1. Okay. If you realize that you do your BE and crying and your patient's urea level is greater than 7 millimoles per liter, it's another value of 1. If your respiratory rate is greater than 30 cycles per minute, okay, that's like similar to the same rates that we are looking out for in severe acute asthma. Respiratory rate greater than 30 cycles per minute, that is also 1. Remember we said when the BP is low, it's a marker of severe disease. So BP less than 90 in terms of systolic and 60 in terms of diastolic, they also will get a value of 1. And then a patient who is above 65 years will also have a value of 1. So when you are done, you just add your values. If you're getting a total value of 0 to 1, it means you're okay. You can actually decide to manage these patients on outpatient basis. Okay. If you're getting a value of 2, it means you need to admit this patient. Above 3 means this patient will require special care, if possible, HDU or ICU. Okay. And to also add to it, you're getting a value of 0 to 1. Even though the light is clear, you can manage this patient on an outpatient. If a patient tells you, doc, I want to be admitted, you won't say, oh, your KEP 65 is less than 2, so no, go home. No. But then the values are there to tell us that in case you should manage this patient on an outpatient basis, nobody will fault you. Okay. So basically, that's it for KEP 65. Rabbi, I saw your hands up. I think you have a question.
I think she typed it in the text area.
Okay.
Yes.
Where is it? Okay, let me see. Chat 2. All right, so when there's consolidation and the lungs harden, what is the intervention? Okay. All right, so we'll get to that in a bit when we are doing management, because that is the basis of managing the pneumonia itself. Your basis for managing the pneumonia is to sort out the consolidation. So we'll be seeing that in the next moment. Okay.
Then there's a second text that says, sir, please, the line wasn't clear. Please kindly go through it. Lorena, which part did she lose you?
Hello.
Yes, Lorena.
Yes, please.
So when you started for the assessment on how to manage a patient, whether you should admit or something. So the line was breaking. I don't know, maybe from someone else.
Okay. So you're welcome. Yeah, so what I was saying was that CAP65 is it's a criteria we use to assess our patients, okay? And it helps us decide on what patient to admit, what patient to treat from home, what patients would require special eyes, okay? So in terms of that, we look at the parameters that have listed the confusion, urea level greater than 7, respiratory rate greater than 30 cycles per minute, and BP less than 90, 60, and then age greater than 65. Once you have this and you've given your numbers, you're going to look out for a total number. Anything 2 and above means that you have to keep the person in the hospital, and anything below 2 means you can manage the patient from home. Are we good?
Yes, Doc. Let's continue.
Yes.
All
Thank
right.
you.
You're welcome. The investigations, very, very key. Once your patients,
hello sir.
Yes,
sir, please.
Yes, please, actually.
Assuming you did assessment and the BP is 87, 80, 60.
Yeah.
Even without pneumonia, patient with BP of 80, 60, you cannot let the person go home. Assuming all the criteria are okay, then the patient has 1 because of the low BP. Would you allow the patient to go home?
All right, okay. So that's a good question. So it would actually be dependent on the patient's clinical state, okay? It will be dependent on the patient's clinical state. If a patient comes to you at the OPD, you assess the patient and you record a BP of 80-60. 80-60 could actually be normal for this patient.
Okay.
Okay, the patient can tell you that, oh, doc, I have low BPs. But if the patient is hypertensive, hasn't taken his antihypertensive drugs, comes to you and you're getting a BP of even 90-60, it should raise an eyebrow. Even if that's only that's one day and you want to go according to CAP65 and say, okay, I don't have space, so you go home. You have to raise an eye because this patient is hypertensive. He hasn't taken his antihypertensive medications, but then you are getting 90-60. Something must be wrong. What you need to do as a clinician, medicine, we follow rules, but then the CAP65 here is not a strict rule that is 1, so go home. You would have to make a decision that BP 90-60, I'll admit you and give you some IV fluids to raise your BP. And the least I can do for you is give you start doses of IV antibiotics and let you go home on the orals so that you come for a review.
Okay.
So in terms of management, we take a lot of things into consideration and then we manage the patient. If I have a patient who is coming to me with BP, only BP of less than 90-60, and everything is fine, and this patient is an adult, it's not 65 yet, but it's 60, I'll still be a little bit rigid when it comes to letting a person go home. I won't say, oh, CAP65, you're not 65 years old, you are 60, but your BP is 90-60, so you go home. No. 60 is a bit closer to 65, and somebody can be 65 and can be very fit than somebody who is 60. So the assessment there is just supposed to be a guide, but you also use your proper assessment to take a look at this patient. If the person BP is 90-60, but the person tells you that he's been sweating a lot and then has been vomiting, it tells you that you can't just discharge the patient on orals because there's vomiting there. You can't just let the patient go home on orals because even though patient is vomiting and it hasn't affected the electrolyte levels, your oral medication going in will come out. Eventually, the electrolytes will be affected. So it's okay to admit this patient. You understand?
Yes.
Okay.
Thank you.
You're welcome. So when it comes to the investigations, you are going to look out for the cause of the infection. That is what you are doing. And you are going to look out for other things that is basically causing the infection, is bringing up like a complication of the infection. Okay, so the cause of the infection, you would want to do a culture basically. If the person is coughing, you would want to take the sputum and then go and look at the sputum for microorganisms. You can also do microscopy. Microscopy will tell you, okay, I saw gram-positive cocci in a chain form. Then you know this is a streptococcus. Okay, so you do a sputum for microscopy or culture. You can also do a Nelson stain for acid-fast bacilli. We are doing this because maybe your patient is coughing and now your patient is telling, when I cough, I see blood in it. You want to rule out TB. So you do an acid-fast bacilli test for the patient. It's a Nelson stain. Then you'd want to see if there's TB over there, it will pick up the stain. Okay. Then it's good to do your full blood count always so that you look out for the WBCs and see if it's elevated and all that. Okay. Then inflammatory markers, C-reactive proteins, ESR, it's also something that you do. It would usually go up when you are dealing with a pneumonia. So it would give you an indication of what to do. Then your BE and quietening, as I said, is essential because even urea levels is used to assess KEP65. Also, once you do that, it tells you that, okay, the patient has a pneumonia. This pneumonia is not only getting to the lungs, the patient is now becoming septic because the pneumonia is spreading into the blood. And once it's spreading into the blood, it's going to cause some form of sepsis and shock. Okay, shock will lead to vasodilatation. Sepsis will lead to vasodilatation and poor perfusion to your vital organs, which will be the cause of shock. Okay, so it's good to do your BE and quietening because once you are in shock, urea levels will go up, quietening levels will go up, and that would be an indication of acute renal failure secondary to the pneumonia. Then the chest X-ray. The chest X-ray is very, very, very key. Okay, so the chest X-ray, usually what you are going to see is the consolidation, okay, which means that you are going to see some form of whitish patches or radio opaque lesions on the chest. So I'm coming, if we can all go to the class platform, and then I'm putting some pictures there so that we can discuss. So just a minute.
So we are there.
Yes.
Just a minute.
Just a minute. Just a minute. I'm putting a last picture there. Okay, that's a good one. Okay, so when we take a look at the pictures over there, the second one, okay. The second one, the one with the two, it has two arrows on the right side. The second picture, can we all see it?
Yes, Doc.
See, the arrow is pointing to a certain area which looks white. So when you take the whole X-ray, look at the left side of the X-ray. You can see it's all black, okay? And then on the right side, even the lower part is black. That tells you there's air in that area. Once there's air there, it means the lung is spongy and all that. But look at the parts where the arrow is pointed, it looks white. This tells you that there's no air there, or it tells you that it is what's consolidated. So this is what we mean by consolidation, okay? And this consolidation is restricted to just one part of the lung, one lobe, okay? You can see that it's more of the middle lobe. The upper lobe also looks a little bit whitish, but it's more on the middle lobe. So we call this what? A Luba pneumonia.
Okay.
Are we okay?
Yes,
So
sir.
this is what we mean by Luba pneumonia. So there's a white feature or an opacification, which is typically found in the whole lobe of a particular lung. When you look at the last picture I posted, you can see, when you look at it well, you see a black background, but on the black background, you see white, like some snowball and stuff there. Okay, so this is patchy opacifications, which is spread all over on the lungs. So the black background is there, but then both the right and the left has what's patchy. So here you can see that the infection has affected both the right and the left. Okay, and this is what we call what's broncho pneumonia. So it's not just restricted to one lobe, but then you can find that almost all the lobes have been affected, but in varying forms. Okay, so that is broncho pneumonia. So that's it. So when you take the X-ray for a pneumonia, this is what you find. Okay, you find opacities. If the opacity is restricted to just one lobe, then you say it's a Luba pneumonia. If it's restricted to all the lobes in a patchy form, then say it's a broncho pneumonia. Now look at the very first picture I sent you. And now we are moving to complication. So when you have a pneumonia, you can get a complication like pleural effusion, which I said that means the pleural space, okay, or the covering of the lung becomes what's filled with what? Fluid. Okay, so comes filled with some fluid. Okay, once you have inflammation, you have exhibits and all that. So there's an inflammation, so it becomes filled with fluid. Once this happens, you see that the pleura is covering, an X-ray shows you a two-dimensional feature, a picture of the lung. That's what the X-ray does. Okay, so it doesn't show you the whole 3D thing, but if it's showing you the whole 3D, you see that the pleura is covering the whole front and then what's the back and then the side. Okay, that's the three-dimensional feature. But the X-ray will just show you two-dimensional. So now how can we tell that there's pleural effusion? So when you look at the chest X-ray on the right, the arrow on the right, they've written clear right side hemidiaphragm and sharp costophrenic angle. Okay, what does this mean? It means when you take a chest X-ray, you are looking at that angle. You see there's an angle there, the last bit where the arrow is pointing to. That's an angle, okay? That angle is called costophrenic angle, meaning it's the angle between the ribs and the diaphragm. See, the diaphragm lies there flat, and then there's a rib. So the angle between the rib and the diaphragm is called a costophrenic angle, okay? Ideally, when you take a look at it, you should see a sharp border, like there should be an angle there. Once you have an angle there, it means there's no fluid. But as soon as you have a pleural effusion, the fluid that is being produced in the pleural cavity will obliterate this angle. So you go to the left, take a picture, take a look at the left. Now there's no angle over there. So the arrow is saying area of homogeneous whiteness with loss of hemidiaphragm. So you can't find any angle over there, can you?
No,
there's no angle.
Yes.
Exactly. And when you pour water in a measuring cylinder, remember when we did science in school, you pour water in a measuring cylinder and then you put mercury in a measuring cylinder, then it'll tell you the meniscus of water is like you, and then the meniscus of mercury is the opposite. Okay, that is what is happening here. So because there's water in there, there's more fluid, you're going to have a meniscus in the shape of water. So when you see where the small arrows are pointing, there's actually what? A meniscus. So look at the arrow, you see that there's something like a U over there. That tells us that there is fluid there. The meniscus is the upper border of your pleural effusion. So whenever you take an X-ray, then there's a loss of costophrenic angle on one side, or even because sometimes you can have bilateral pleural effusion. So you check and there's loss of costophrenic angle. You can't find any sharp border. The next thing you're looking for is a meniscus. The meniscus is the level of the effusion. So if the meniscus is way up in the middle aspect, that means the effusion is climbing up. Okay, so you can have the meniscus over there, and that tells you there's fluid in the pleural space. So that is the pleural effusion we are talking about. Okay, how do we manage this? Well, yes, please.
He said if the consolidation is in one lobe, they said it will be Luba Pneumonia.
Yes.
So
if it's capturing the whole lobe or the right.
Yeah, so let's say consolidation is either one lobe of the left or one lobe of the right is Luba Pneumonia.
Of the right, yes.
Now what if the consolidation is in the left in all the lobe, or the right all the lobe?
What if the consolidation is what?
So you have all the lobes in either the left or the right.
Or the right.
Yeah.
All right. Okay. So then it doesn't become just a normal Luba pneumonia. You have a pan Luba pneumonia. Pan means all the lobes.
Okay.
Sometimes you can have a bilateral Luba pneumonia, meaning a lobe on the right is affected and then a lobe on the left is affected. Or you can have a left pan-lobar pneumonia, means the two lobes of the left are all affected, or a right pan-lobar pneumonia because the three lobes on the right are all affected.
Okay.
Did you get it?
Yes, sir. Thank you.
All right, okay. That tells you are dealing with a more severe infection.
Okay.
Sir.
Yes. Hi.
With what's happening with the first picture, the one you just explained with the meniscus shape.
Yes, yes.
Can you think that this is also a lobar pneumonia since it is just the lower part, one lobe that is affected in this case?
All right, okay. Yes, so when you take a look at it, you can say that, but I see the difficulty here. Well, clearly this is a lobar pneumonia, but the difficulty here now is that you see, sometimes once you have a pleural effusion forming, the fluid will obliterate and you have a lobar pleural effusion forming, and then your pneumonia is on the lower aspect. The fluid that forms, just like water, when you pour, the water is supposed to start from the lower aspect and go up. So the fluid can obliterate your pneumonia and you can't see it properly. Okay, because you could also have, when you take a look at it clearly, you could have a broncho pneumonia. You can see some other white patches there on this X-ray, right? You can see some, look at the middle aspects coming to the outer, there's some white patches. It's not like classic, but if you got white patches in all those areas, you could also have a pleural effusion, and this pleural effusion will start from down. Once it starts from down, it will still look whitish and it will make you feel this is a lobar pneumonia, but then that actually won't be a lobar pneumonia. Okay, I'm trying to say once you have a pleural effusion, the fluid will look white. It's starting from the lower aspect. If you don't take care, you are going to diagnose all pleural effusions as lower pneumonias and lobar pneumonias on the side of the pleural effusion.
Thank you.
You get it?
Yes, sir.
Okay. So basically, yeah. Apart from a pleural effusion, you can have a lung abscess. Okay, so you take the lung and you have areas filled with pus all around. Then you say, okay, there's a lung abscess. Sometimes you can have the pus moving into the pleural space, and then you say this is what is called what? An empyema thoracis. Okay, empyema thoracis means that you have an abscess or pus in the pleural space. So it's a type of pleural effusion, but in this case, it's not just water or transudate or whatever that you have in the pleural space. Instead, you have pus in the pleural space. Okay. Sometimes, because of the pneumonia, you can rupture the pleura. And when you rupture the pleura and you breathe in, it traps air into the pleura. And once it traps air into the pleura, you are going to have a pneumothorax, okay, which we said when you percuss, you are going to find hyperresonance. So whenever the pleural space is ruptured, a part of the pleura is ruptured and you breathe in, air would move into the pleura, and then you are going to have what pneumothorax, which would be hyperresonance on percussion. Then the infection can spread to the mediastinum. The mediastinum is where you have the heart, so it can spread, and then you have pericarditis and pericardial effusion. It can spread into the whole blood. As I said, you can develop sepsis, shock, multiple organ failure. It can spread into the brain. You get meningitis, okay, and then adult respiratory distress. So those are the complications. So when we ask you to tell us complications of pneumonia, first think about complication of the lung parenchyma, then think about complication of the pleural space, then think about complication of the mediastinum, and lastly, systemic complication. So it's 4. Okay, the complication of the lung parenchyma is a lung abscess and all that. Complication of the pleural space is pleural effusion, empyema thoracis, or what, a pneumothorax. Then complication of the mediastinum is pericardial effusion or meningitis, acute kidney failure, and all that. The management, what you are going to do is you want to treat the infection. That's it. When you treat the infection, you sort out the consolidation. So, Rabi, that's the answer to your question. Your aim is to focus on treating the infection with antibiotics. And once you treat the infection with your antibiotics, the blood flow and things would improve. The lung becomes spongy and the consolidation will disappear. So that is how you sort out the consolidation. So that's the first thing. Then you have to put your patient on some IV fluids, because pneumonia is some hyper states which will give you fever, you sweat, you lose fluid, you can vomit and all that. If your temperature is high, we need to give you some antipyretic treatment, so some PMO would do the trick. Then you check the diet, the patient, you make sure your patient is eating well and all that's very, very necessary. Okay. So the antibiotic is like, it forms the basis of this treatment, because that is what is going to sort out the infection proper. So the antibiotic that's ideally you give to manage pneumonia is dependent on the organism you pick during your culture. Okay, can you hear me, please?
Yes, Doc.
Yes, sir.
All right, okay. So the antibiotic you give is dependent on the organism that you pick up during your culture. But the thing is, your culture will take about 72 hours. You can't wait for 2 to 3 days before you start managing your patient who has pneumonia. What you do is you start what we call empiric treatment. And once you start this empiric treatment, the empiric treatment would sort you out whilst you wait for your culture. Okay. What is empiric treatment in this case? Empiric treatment is you are thinking of the possible organisms which can cause pneumonia and then target your antibiotic to these organisms. So if we go back, that's where the types of pneumonia is necessary. When you are thinking this is a community-acquired pneumonia, then you are thinking of gram positives, some gram negatives, and then some atypical organisms. Okay, if you are thinking this is aspiration pneumonia, then you are thinking of gram negatives and what anaerobes. So that is where the type of pneumonia or the location of the pneumonia is important. Okay, so if you have a pneumonia and you are thinking of gram positive organisms, you give the penicillins. So amoxiclav usually, that's my P drug. Okay, some people can give penicillin 1 gram 6 hourly. I feel it's a bit archaic. Well, you can do augmentin 1.2 gram 8 hourly. Okay, and then if you are thinking of gram negative, you can give your cephalosporins. So ceftriaxone is 1. You can put the patient on Rucefin. It will sort you out if you are thinking of gram-negative. Gentamicin is also used to manage gram-negative. So the gram-negative, you can use cephalosporins and then your aminoglycosides to manage your gram-negatives. Okay. The cephalosporins, usually you have about 5 generations. So as the generations go up, it moves more towards a gram-negative activity. So first generation and second generation will be more gram-positive. Okay. Third generation means it's getting more gram-negative, fourth more gram-negative, fifth more gram-negative. So Rocephin has, or ceftriaxone, which is a third generation, has a gram-negative activity and a very small gram-positive activity. And that's why people say it's broad spectrum. Okay, it covers gram-negatives and some gram-positives, but mainly we use it when we are thinking of gram-negative infections. Okay, so the cephalosporins and aminoglycosides. Example of aminoglycoside is gentamicin, amikacin, all those things. They are aminoglycosides. Those are for gram-negatives. When you are thinking anaerobic organism like aspiration pneumonia, that's where your flagell comes in. Flagell treats anaerobic organisms. Okay. And then your atypical organism is where the azithromycin comes in. Okay. So it's not wrong to give all the 4 groups if you don't know what you are managing, because you are doing empiric. So you are giving something called for gram-positive, gram-negative, anaerobe, and then atypicals. It's not wrong. However, if you know this looks like it's an aspiration pneumonia, you have no business going to give a gram-positive. You give your anaerobe cover, which is metronidazole, and then a gram-negative cover, which is a cephalosporins or aminoglycoside. So with the aspiration pneumonia, you go ahead and put the patient on metronidazole and cipro, metronidazole and gentamicin, something of that sort. Okay, and that is the reason why when you are treating GIT infection like gastroenteritis and all that, we give ciproflagyl. It's because we are targeting what gram-negative, which cipro will target, and anaerobe, which metronidazole will target. You understand? So basically, that's how you deal with it. And using this basis, you can actually manage every infection that comes your way using this P drug. Oh, patient is coughing, cough, cold. I think this is gram-positive. Okay, let me give penicillin. So amoxiclav will come in. Okay, patient has a UTI. Commonest cause of UTI is E. coli. E. coli are gram-negative organisms. Okay, what antibiotic can I use for gram-negative? Cephalosporins or aminoglycosides. So let me either give, or fluoroquinolones. Okay, let me either give cefloxime or cipro or gentamicin. So that's how you give your antibiotic. Patient has diarrhea and vomiting. This is GIT. So this could either be gram-negative and anaerobe. So let me give ciproflagyl or cefloxime flagyl. Okay, so basically that's how you give your antibiotic. Any questions? I think the link will drop soon.
Sir.
Yes.
And this one, like this one, has nothing to do with it. We haven't done the arterial. The slide has been given, but you have not.
Which one? We haven't done what?
The arterial. What do you call it? Fibrillation.
The atrial fibrillation. Yes. So I was saying that it will be better we do that one in class because of the ECGs and things that come with it. So we'll do that next week in class.
And the slides for the heart attack, the blackout.
Yes, the cardiac arrest. I thought you had slides. I haven't given you slides.
No.
All right. Okay. Then I'll send it to you. Okay. Any other questions, please?
Yes, sir, please. When it comes to the classification of pneumonia, we talk about Luba pneumonia and Broncho pneumonia.
Yeah.
So where would the pan-Luba pneumonia fall?
Oh, the pan-Luba pneumonia is just a type of Luba pneumonia. Just that it's affecting more than one lobes.
Okay.
All right.
Doc, in the chat. Okay.
Yes, please.
Please go ahead. Somebody was asking the question.
Yeah, so I wanted to ask, looking at the first picture you display on the page, that is the Costophrenic Angle, and the other side that you described. you could see that the angle is not there. That doesn't mean that the angle is being filled with the fluid. And in this case, the angle is being destroyed, or the angle over there is being destroyed, or it has been just been occupied with the fluid.
Okay, so good. So the angle hasn't been destroyed. If the fluid drains, you have the angle back. So the angle is actually there, but because of the fluid has what? Covered that angle. So you can't see the angle. So when the fluid drains on your treatment, the angle would return.
Okay. Okay. And then secondly,
so it's just obliterated.
Okay. So surgically, can you do water and the sea drainage to drain the fluid over there?
Yes.
But I didn't see that one in your management.
Yes. So I left that one for the surgeons, but I intended to talk about it. So pleural effusion, what you do is you pass the chest tube. And when you pass the chest tube, as you are saying, you do the water and the seal management. It drains, and then the fluid in the effusion comes out. Okay. So you pass it. That's how you manage pleural effusion. You need to pass a chest tube.
Okay. Okay. Thank you
Sir,
very much.
please, what role
You're
does
welcome.
diuresis have in the pleural effusion management? Because sometimes you see the prescriber giving diuresis.
Yeah, so just like the way it works for the edema, the ascites and all that.
Doc,
yes, please.
Not to cut you, but I don't think you may be able to finish this question. So actually, if you can pause on your question, and then maybe we can start another session. Then you can bring your question.
All right.
I'm okay with the answer. I'm okay, but if we all want to come back.
Yes, because there are 3 other questions in the chat that would have to look at.
Okay.
All right. Okay. So then let me just drop it and then send a new one. Okay.
All right, Doc.
Okay.